Next speaker is Dr. Indira DURAI. She is a senior consultant at Arvind Eye Hospital, Madurai, and she is going to speak on how to diagnose failing bleb and role of AIOCT. Over to you, Dr. Indira.
Good afternoon, everyone. At the outset, I'd like to thank Dr. Devendra sir for this opportunity. I'll be discussing about the role of anterior segmental OCT in the identifying failing blebs. So, as mentioned by previous speakers, trabeculectomy continues to be the gold standard in the surgical management of glaucoma, the success of which depends on the formation of a functioning filtering bleb. Therefore, bleb morphology is an important predictor for a successful surgical outcome, as it is considered as an indicator of shunt function and also as a predictor of bleb-related complications. Clinically, bleb appearance can be classified as diffuse, cystic, encapsulated, and flattened. A good intraocular pressure control, that is an IOP of less than 21 millimeter of mercury after filtration surgery, is usually associated with a low-lying diffuse bleb. So bleb morphology can be clinically evaluated by various methods, such as slit lamp examination and photography, and imaging methods such as ultrasound biomicroscopy and anterior segment optical coherence tomography. A careful slit lamp examination is important for the evaluation of a filtering bleb function and also for recognizing signs of early bleb failure. An ideal functioning bleb has a diffuse and a slightly elevated appearance. It is avascular and transparent and is characterized by a presence of microcysts, whereas a failing bleb is characterized by decrease in the bleb height. They may have a flat appearance, vascularization of the bleb, or the appearance of corkscrew vessels, and loss of conjunctival microcysts. They may present as an encapsulated bleb or a tenon cyst and are usually associated with a raised intraocular pressure. So ultrasound biomicroscopy enables the visualization of internal structures of the bleb, such as the formation of a cavernous fluid-filled space and intra-bleb reflectivity. The UBM has a 91% sensitivity for predicting functioning blebs, but only about 70% specificity for predicting non-functioning blebs. Thus, the anterior segment OCT has been used to correlate bleb structure and function, showing morphological features that can help distinguish between a successful and failed bleb. So anterior segment OCT was first demonstrated in 1994. It provides a cross-sectional three-dimensional image. It's a non-contact high-resolution imaging modality with an axial resolution in the range of 3 to 20 micrometers. The principle of OCT is based on low coherence interferometry, and which measures the delay and intensity of backscattered infrared light using a superluminescent diode, and it provides about 6 millimeter tissue penetration. The posterior segment OCT usually uses a lower wavelength of light, that is at 830 nanometer, whereas an anterior segment OCT uses a higher wavelength, that is at 1310 nanometer. So anterior segment OCT provides critical information about internal structure of the bleb, such as the images of the bleb wall, cavity, flap, and the ostium. It can image the intrascleral lake seen in non-penetrating glaucoma surgeries and implants used in glaucoma drainage devices. Early postoperative morphological features have also been described by anterior segment OCT that can help to predict late bleb failure, that can guide the ophthalmologist in performing interventions such as needling and suturelysis at an appropriate time in order to optimize bleb function. So anterior segment OCT is preferred over slit lamp examination, as it provides an objective assessment of the bleb morphology and function. The slit lamp examination does not show internal structures, which is important not only in determining the bleb function, but can also provide information about wound healing process after trabeculectomy. AIOCT has several advantages over UBM, such as it is a non-contact procedure. Therefore, a coupling fluid is not required and can be performed in a supine position, and also as such it does not carry any risk of bleb infection, which is an important feature which can be used in the early post-operative period. It also provides a higher axial resolution compared to UBM, and it has a high scan speed and therefore less time consuming. Time domain anterior segment OCT is preferred over spectral domain OCT for assessing bleb function, as it penetrates more deeply into the sclera. So anterior segment OCT examination provides assessment of both quantitative and qualitative parameters. The quantitative assessment by AIOCT provides information such as the bleb wall thickness, the bleb height, bleb pattern in terms of microcysts, presence of subconjunctival separation, and multiple internal layers, and the height and extent of internal cavity. The qualitative assessment by ASOCT can provide information about the presence or absence of bleb ball thickening, bleb ball reflectivity, presence of microcysts, which is seen as small round hypodense spaces in the surface of the bleb, and also information about the bleb cavity, ostium, scleral flap, and the subflap space. So anterior segment OCT can be used to differentiate between functioning and failing bleb, either based on the global appearance and or based on the bleb ball reflectivity and or based on the internal bleb morphology. So based on the global appearance, blebs with a diffuse or a cystic morphology have been identified as a functioning bleb, and those with an encapsulated or a flattened appearance have been identified as a non-functioning bleb. So this is a OCT image of a diffuse filtering bleb. This is characterized by the presence of subconjunctival fluid filled space collections with a low to moderate intrableb reflectivity. The cystic bleb is composed of a large hyperreflective area which is filled with the multiple fluid collections of varying size and intensity. The encapsulated bleb has a fluid-filled space surrounded by a connective tissue with a very high signal reflectivity. Flattened bleb does not show any bleb elevation, but it has high scleral reflectivity, and the outline of the scleral flap and sclerotomy were identified. So based on the bleb ball reflectivity, the blebs were classified as those having uniform or multiform reflectivity. So blebs with an uniform reflectivity were characterized by the absence of fluid-filled hyperreflective spaces in the subconjunctival space. They were seen as smooth hyperreflective wall, and these blebs showed increased chances of failure, whereas blebs with multiform reflectivity showed presence of small multiple fluid-filled spaces, which were seen as hyporeflective areas in the conjunctiva, and these blebs were associated with an increased chances of success. So based on the internal bleb morphology, the functioning bleb had the following characteristics on ASOCT. A visible root beneath the scleral flap, conjunctival thickening and subconjunctival fluid collections suggesting adequate aqueous humor drainage and a better IOP control, presence of a large internal fluid-filled cavity, which is seen as an extensive hyporeflective area, thicker and higher bleb balls with more microcysts, and multiform bleb ball reflectivity were found to be good indicators of bleb function. Uniform blebs with no signs of fluid were found to be associated with a higher intraocular pressure, especially during the early postoperative period. Narrow widths and filtration openings on the scleral flap, low bleb ball, thickening of the bleb ball which was typically absent, ostium occlusion, and high reflectivity between the conjunctiva and the scleral flap were features of a failing bleb on ASOCT. This ASOCT had few limitations, such as the disability to image bleb vascularity, and it does not provide microscopic information such as epithelial stromal microcysts as seen in confocal microscopy. And features indicative of bleb inflammation or infection could not be detected by this modality. So thus to conclude, ASOCT proved valuable in the early identification of signs of failure, which was critical for bleb management, and the reflective appearance of bleb ball and width of filtration opening, which was analyzed by ASOCT, were considered important predictors of post-trabeculectomy outcomes. Combining both the clinical and imaging information could provide a new perspective towards understanding the different surgical outcomes after trabeculectomy, and this is important to refine surgical techniques and evaluate different adjuvant treatments in surgical management of glaucoma patients.